All right, let's talk about something that's really changing the game in surgery, patient blood management. If you're in orthopedics, whether you're a surgeon or a clinician, this is for you. We're going to break down a practical, evidence-based guide that can seriously improve your patient outcomes. So let's jump right in.
So, why all the talk about PBM? Well, the numbers really tell the story, don't they? Just look at this, a 26% reduction in red blood cell units transfused per patient. That's the average, by the way, after just one hospital put a PBM program in place. We're not talking about a minor tweak here. This is a massive shift in how we think about and protect our patients' blood.
And the stakes here are, well, they're incredibly high. What we now understand is just how critical a patient's blood health is before they ever get to the OR. Think about this. Even mild pre-op anemia is an independent risk factor for major complications and even death 30 days down the road. This isn't just a nice to have. It really makes PBM a non-negotiable for keeping our patients safe.
Okay, so what's the answer? It's patient blood management. But I want to be super clear about what this is. PBM isn't just one single thing you do. It's a whole framework, right? It's an evidence-based approach to managing and protecting a patient's own blood across their entire surgical journey. We're talking before, during, and after the procedure. And it's all built around 3 core pillars, which we're about to walk through.
So here's what we're going to cover. We've already touched on the case for PBM. Next up, we'll get into the 3 pillars: preoperative optimization, then intraoperative conservation, and finally, data-driven transfusion. And to wrap it all up, we'll look at the evidence that shows just how much this improves patient outcomes.
All right, let's dig into Pillar I, preoperative optimization. I love the subtitle here, building a stronger patient before they enter the operating room. That's exactly it. You can almost think of it as prehabbing a patient's blood. The whole idea is to be proactive, not reactive, and get them in the best possible shape before surgery day.
And what's so great about this first pillar is how straightforward the strategies are. We're talking about things like screening for and really getting after anemia, ideally 3 to 4 weeks before the operation. That gives you a window of opportunity to use tools like IV iron to boost the patient's own red cell mass. And for those high-risk patients, well, that's where something like erythropoietin, or EPO, can be an absolute game changer, basically telling the bone marrow to ramp up red blood cell production.
Now, this leads to a really important point, a real shift in how we think. For a long time, right, we did preoperative autologous donation, where patients would bank their own blood, but we've learned a lot since then. The evidence is pretty clear that this can actually cause anemia before surgery, and a lot of those units never even get used. So now, the literature really supports a much more targeted approach, using EPO for those high-risk patients, because it's just plain more effective.
Okay, moving on to Pillar 2, intraoperative conservation. So, we've optimized the patient beforehand. Now, the focus shifts to the OR itself. It's all about minimizing blood loss, from the very first incision right through to closure. We want to conserve every single drop we can.
And this really is a team sport. It's not just on one person. The surgeon has a huge role, of course, with meticulous surgical technique, using diathermy, for example. The anesthesia team has their own toolkit, with things like controlled hypotension. And then you have these incredibly powerful strategies the whole team uses together, like cell salvage, which is just fantastic for recycling the patient's own blood, and of course, antifibrinolytics like tranexamic acid, or TXA, which has pretty much become a standard of care in orthopedics.
But look, sometimes, despite our best efforts, you're going to face some massive hemorrhage. And when that happens, having a clear, well-rehearsed massive transfusion protocol, an MTP, is absolutely critical. It can literally be a lifesaver. The key is a rapid, protocol-driven response. You hit the button, and everyone knows what to do. You start with universal blood products, not just pumping in crystalloid. You're giving plasma and red cells in a balanced 1-to-1 or 1-to-2 ratio, adding platelets, and you get the blood bank to automate cooler delivery until the situation is under control.
And that brings us to the third and final pillar, data-driven transfusion. I love the subtitle here, using evidence, not dogma. That's perfect. Because if the first 2 pillars are all about avoiding the need for a transfusion, this one is all about being smart when you do have to transfuse. It's about making that call based on real data, not just an old habit or a single number.
And this isn't some radical new idea. The momentum here is huge. You have major players like the European Society of Anesthesiology and Intensive Care putting out formal recommendations for a restrictive transfusion strategy. And this quote gets right to the heart of it. It's all about reducing a patient's exposure to donor blood, because we know that comes with its own set of risks.
So what does that modern transfusion trigger actually look like? Well, it's way more sophisticated than just looking at a single hemoglobin number. Yeah, a restrictive trigger, somewhere in that 7 to 8 grams per deciliter range, is a great place to start. But the real game changer is using point-of-care viscoelastic assays, like TEG or ROTEM. These tests give you a dynamic, real-time picture of how the patient's blood is actually clotting. This lets you move to targeted component therapy. You're not just guessing, you're giving the patient exactly what they're missing, right when they need it.
Let's make this really concrete. This table lays out some of those specific, actionable triggers. So for instance, if you're using ROTM and your MCF FibTem comes back at less than 8, boom, you know that patient needs cryo or fibrinogen. Or with TEG, if the MA is under 55, you're thinking platelets. This is exactly what we mean by data-driven, goal-directed therapy. It is worlds away from the old one-size-fits-all approach.
Okay, so we've walked through all 3 pillars, but what does it all add up to? What's the bottom line? This is where the rubber meets the road. We're going to look at the hard data that proves, without a doubt, that a full PBM program is a massive win for our patients. And for anyone in orthopedics, this chart is just wow. It shows the incredible impact a PBM program had on patients getting hip and knee replacements. You can see the transfusion rates just plummet for both procedures. And we're not just talking statistically significant here. These are clinically massive reductions. This is what happens when you put that 3-pillar strategy into practice.
But here's the real kicker. The benefits are so much bigger than just using less blood. And if you take away one thing, this should be it. When you implement PBM, you see better patient outcomes across the board. We're talking reduced 30-day mortality, fewer nosocomial infections, shorter hospital stays, and lower readmission rates. So this isn't just about being smart with the resource. It's about delivering fundamentally safer, better care that gets people home and back to their lives faster.
So, the question we want to leave you with is this. How can you take these 3 pillars and use them to strengthen your own perioperative plan, from that first preoperative checkup to your technique in the OR to how you manage the patient afterwards? The evidence is just overwhelming. A structured PBM program is one of the most powerful things we can do to improve outcomes for our orthopedic patients. It's really time this became the standard of care everywhere.